Hi, everyone. As you guys are coming in, welcome to our Well by Messer Wellness Wednesdays. If you guys have come before, welcome back. And if you are new, welcome for the first time. We're happy to have you guys here. This is actually our week 5. This is super, super exciting. We've got a great topic today about bone health and nutrition. But we also just wanted to recap for some people who might not have been here in the past weeks. We've discussed glucose management. We've discussed fueling your workouts. We've discussed metabolic health with Dr. Shabra. And then last week I did some myth busting, which, I always think is fun because some people are like, I didn't even know that was a myth. So it was super fun. We had a nice conversation. So again, thank you guys for joining us today. My name is Catherine Staffieri. I'm a registered dietitian here in the Greenwich office at Well by Messer. I've been here for a couple of months since March. This is really one of my favorite things to do is to have these kinds of webinars, education hours where people can discuss. I always say this every time. This should really be casual. It should be fun. Please feel free to interrupt us. Please feel free to add your comments or your questions in the chat, and we can always stop halfway through or, roll back a few slides. So this is really, it should be interactive. It should be fun. There's no wrong question. There's no dumb question. We're just all here to learn and enjoy this great topic. So today we have the honor of having Dr. Shelly Im with us. And she is also she's an endocrinologist here in our Greenwich office. And I will turn the floor over to Dr. Im to introduce herself to everyone.
Hi, everyone. Thanks, Catherine, for setting this all up, and I'm really excited to be here today. Just a few words about my history. I've been an endocrinologist for 15 years now. I did all my training, medical school, even undergrad, residency, fellowship, all in New York. Most recently, I was working at a multi-specialty practice in Westchester called, formerly known as WestMed. I was there for almost 10 years. But I was really happy to join Well by Messer last fall. And I have a really long-standing relationship with Dr. Messer and her team at the Well by Messer in the city. So it's really exciting for me to be a part of this group. So thank you so much for having me. And I hope you all can learn something today.
Right. Well, we are excited to have you. And I think this is a great topic, right? A lot of times people, well, I would say maybe a lot of buzzy topics for endocrinology right now are more maybe like thyroid issues or things like that. But I think bone health, you and I were discussing this yesterday, is so topical, especially sort of in a preventative medicine way. You don't want to be talking about it after the fact, right?
Absolutely. And I feel like the more and more that I talk to, especially women, about, kind of like their current health symptoms and issues that they're having, it's definitely worse to find out after the fact that you've been potentially diagnosed with something such as osteoporosis, which is often a silent condition that you don't even know you have. And then to have to worry about the repercussions of having a diagnosis like that when you could have potentially prevented the onset of a diagnosis by doing some very simple things earlier in a preventative manner.
Absolutely.
So, basically, what we know is that many men and women actually are at risk for bone loss, and it can start as early as your 50s. And actually, if you look at the numbers, you'd be actually pretty surprised to see how often this happens. And again, because it's a silent condition, you don't even know that it's developing. By the time you actually realize that you might have an issue, it's kind of already too late. You missed the boat. 51% of women over the age of 50 do have evidence of low bone mass, sometimes on an imaging study. It's accidentally picked up when you have an x-ray done for, like maybe like some knee pain. And it turns out that even 20%, 1 in 5 women actually end up having the diagnosis of osteoporosis by the time they're 50, which is really quite early. It doesn't seem to be diagnosed as often in men. But it is still a diagnosis that has to be considered when evaluating men for any health issues. And so you can see the numbers that it's still prevalent. I mean, 4% of men over the age of 50 are diagnosed with osteoporosis, which is probably surprising to a lot of people. But it definitely affects both men and women. And the older you get, the much more likely you will experience an osteoporosis related fracture. So it is definitely something to raise your awareness of early on so that you can get on the bandwagon of how to kind of prolong your health and not put yourself in a situation where you get this diagnosis.
And can you just unpack the term low bone mass? Because I don't know that everyone's familiar with that. If your doctor says to you, "Oh, you have low bone mass," like what does that mean?
So that's a great question. And I think we talked about it a little bit yesterday because I think in terms of terminology, the term osteopenia has always been used, and it is still used in the medical literature as kind of like on the spectrum of bone architecture. And I think the reason why it's fallen out of favor from a healthcare professional standpoint is because a lot of people feel like that it is considered a medical diagnosis and it implies that treatment is needed. So low bone mass is more of like a stage of your bone health where you don't necessarily have to give it a diagnosis and associated with a need for treatment, but it is kind of just to raise awareness that if you are someone with low bone mass, that you are predisposed to developing a significant bone issue like osteoporosis. But I think it's really because it carried this like negative feeling that you would need medication for osteopenia. So they kind of started to try to use other more, I want to say more benign phrasing just to make it seem like it's not such a bad diagnosis.
Yeah. No, I think that, and again, it goes back to that sort of preventative health that obviously we're trying to do here at Well by Messer, right? This is just another one of those, chronic health conditions that we're trying to get ahead of, much earlier than. So, and even if you do have something, if your doctor says, "Oh, it looks like you have low bone mass," it's not a true diagnosis, right? And there is stuff that, you can do to prevent it going further into osteoporosis.
Absolutely.
Great. Okay. You want me to hop to the next slide?
So interestingly, our bones are growing, pretty much our entire lives. We have bone cells that are producing bone and laying bone down. And we also have bone cells that are reabsorbing bone and trying to maintain a stable bone dynamic throughout our lives. In the early stages of life, when we're growing, obviously in childhood, we have an overproduction or like a balance in favor of bone production over bone resorption. And that's why we're able to grow and get bigger and get stronger. And we do accumulate a significant amount of our bone mass by our late teens. And we always tell people that by early adulthood, by like your early 30s, or classically we say 30 years old, you've reached your peak bone mass for most people. And so once you've hit that point in your life, your bone dynamics generally remain stable as long as you have a healthy lifestyle that's supporting stable bone development, which means having the proper tools to maintain your bone, which we'll talk about later on in this conversation. But there are definitely people who don't accumulate a good peak bone mass for various reasons. If you're not a big milk drinker as a child, you're not exposed to as much calcium, you're already going to have a peak bone mass that's potentially lower than someone who drank 3 glasses of milk every day. So these little things that start really early in childhood can definitely dictate your kind of like long-term journey and in terms of your bone health. So these are kind of things that we like to pay attention to. And if you have children, these are kind of the reasons we harp on, oh, they need to drink milk, they need to get their calcium, they need their vitamin D, they need the sun. All of these things are going to play a role in how they're able to build up their bone mass, because that does peak. And then once you hit like middle age, you start to have this kind of like discrepancy where you're going to have a little bit more bone loss and and a little bit less bone production. By the time women reach their perimenopause transition, which can take several years, there's a lot of data that shows that the amount of bone loss is probably across that span of several years, 10%. And so by the time you drop your period, which we call, menopause, actually 12 months after your final menstrual cycle, you've probably already lost 6 or 7% of your bone mass. And if you wait until after menopause to start screening your bone density, it's going to potentially show osteopenia, or low bone mass. And at that point, you're already down this path where potentially if you made these changes before that happened, you might have a much better result if you did that same bone density test at that point. So these are definitely things where, in women in their late 30s, early 40s, it's even more important because once estrogen deficiency starts to happen, you're really going to see a significant acceleration of bone resorption. And then usually once the menopause transition is completed, which again, it's generally like a 10-year period of time, then you will see kind of a stable bone loss. But because estrogen is really gone, you're still going to be in favor of bone loss over bone growth. The cells that are producing bone are still functioning, but they definitely don't function as well as they did earlier in life. So again, these are all changes that are physiologic that we know are going to happen. And these are points in time where we can try to make some changes to really slow down the negative effects and really reduce our risk of developing osteoporosis and increasing our risk for fractures.
Definitely. I actually, as a little anecdote side note, I remember when I was in school getting my nutrition degree, we were talking about like childhood and adolescent nutrition, and they actually tied it to osteoporosis. I was like, wait, what are you talking about? And they were like, well, it's almost a disease that starts in the teenage girl. It's like, for women, they need to be building this bone in the teenage years. And so many of them are dropping these calcium sources in their diet. And so that's why it's so important to, really emphasize that when they are younger, because it has a huge ramification, when they are older.
And absolutely. And even, another common, scenario when talking about young women is, anorexia, bulimia, eating disorders. One of the symptoms that often happens when you have low body weight is you drop your menstrual cycles, and that loss of estrogen because of the signal not coming from your brain to your ovaries to make estrogen. It's similar. It mimics what you would expect in a menopausal woman. So if someone has eating issues as a teen, that is one of those situations where by the time you reach your peak bone mass, you might not have achieved that peak bone mass because you had a period of time when your estrogen was not protecting your bone. So again, like more reasons to kind of keep those things in mind as if you have teenagers who are like kind of developing as a young women. These little details are really important because in the short term, obviously, if they're eating issues that need to be addressed, the long-term issues are kind of like the repercussions in terms of bone health.
Got it. Yeah.
So traditionally, the standard screening tool for bone density testing and osteoporosis diagnoses are with something called DEXA scans, which stands for dual energy X-ray absorptiometry. And it basically is taking pictures, and it's not much more radiation than if you had broken your arm and you needed to do an X-ray. But this is the gold standard that we still use today for bone assessment. It is the most accurate measurement of bone density. It also is used in other situations. So it was validated by the World Health Organization to study postmenopausal women's bone density specifically. So when we look at the bone density reports, the T scores are really designed to be addressing postmenopausal women. However, we do still use these scores as a way of kind of explaining how bone density changes can affect people on an individual basis, and the scores are still, pretty useful. Um, there are different parts of a bone density test that I'm happy to go over. But the bottom line is when we look at a bone density report, we have a pretty good idea if you are at high risk for fractures. Because really, at the end of the day, why do we care so much about osteoporosis and bone health? Because osteoporosis related fractures can definitely, especially hip fractures, can cause significant comorbidities. There's definitely an increase in mortality, reduced quality of life. In terms of hospitalizations, I mean, we spend billions of dollars on patient care because of these hospital-related fractures. My aunt, who, is a personal anecdote myself, my aunt, who was living in Korea, had a stroke, and she fell and broke her femur. And then while she was in the hospital after the femur fracture, she had many complications, and she actually ended up passing away earlier this year. And what I take home from that was that her balance was off because of her stroke, and she fell, and she was in her early 70s, and she had other health issues. But once that happens, you get this cascade of events that are out of your control. But what was controllable was if she had known she had osteoporosis before all these events happened, and maybe if she had treated it, that would have reduced her chance of fracturing in that situation. So it's really good information that you need to learn about yourself so that you can take the proper precautions and take the proper steps to kind of reduce your chances of being in that situation. Because I feel like once you get diagnosed with osteoporosis and someone starts to talk to you about medications, that's also another whole conversation that we can have that is a very difficult one for many people, because you don't feel osteoporosis until you break something. So it's hard to wrap your head around, well, why do I have to do something about it? But when you see examples like this, especially on a personal level, it will make you think twice.
Yeah.
So who do we normally screen? If you could see, across the board, and this is based on many different society guidelines, every woman by the age of 65 needs to have a bone density test. We also recommend men, obviously, because men are at risk for osteoporosis. They should start screening as well. And traditionally, the standard time frame is 70 years old. There are exceptions. And of course, I often order bone density tests for men and women much younger than the recommended age. So, it has to do with someone's increased risk for fracture. So risk factors. Women between the ages of 50 and 64 who are menopausal and may have one additional risk factor. For example, they may have celiac disease, which is a malabsorptive syndrome where you might not have good nutritional status, or if you've had a fracture where you tripped down a step in your house, or if your parent broke their hip and had severe osteoporosis. Taking into account your risk, your genetic makeup, you would be a candidate for bone density testing earlier than this recommended age of 65. And a lot of times, once someone is on medical therapy for a diagnosis of osteoporosis, we do often use the bone density scans to monitor whether the treatments are working and whether we can actually take them off medication, which is often a possibility. Again, and we can talk about the T scores and the Z scores, but these are, again, kind of like when you come to your doctor's office and you have a report, someone should definitely go over all these numbers with you and give you an explanation as to how this applies to you and what is your risk and what you can do about it.
Great. And where do people go for a DEXA scan? Are they only in hospitals? Are they standalone? What's your experience with them? Are there better scans and not better scans? I'm not super familiar with it.
That's a good question. I think so. Most radiology facilities, outpatient or hospitals, have the ability to do bone density testing. A couple of things to keep in mind is that all machines are not built equally, but the most commonly used brands in the United States States are all pretty well validated. So there's not one particular brand that I think is better than another brand. For example, I think one location they use a Hologic, another location they use a GE Lunar. But what's important is consistency. So especially if you are a candidate to try medication for bone loss or osteoporosis, you want to make sure that your subsequent bone density tests are on the same scanner, because one of the most important pieces of information that we like to see are the trends. So if you go to a location and they have a different machine, it's not necessarily comparable. So we always like to recommend try to stick to a place, even if you don't. If you live far away, obviously, then we'll have to switch to a new and then just start over from scratch in terms of having a new baseline. But if you have access to go back to the same bone density machine, then definitely you should continue to use the same bone density machine, just because that will carry your history through.
That's so interesting. And I think so much of what you're doing when it's preventative medicine is looking at the trends, right? Is like, even
Absolutely.
with like insulin levels, glucose levels, things like that, like you're looking at the trends over time and are we trending up? Are we trending down? So absolutely. Yeah. I love gathering data, right?
Yes. And as I mentioned earlier, obviously hormones, endocrinology. Why does osteoporosis fall under the category of hormones? Estrogen deficiency is probably the most common cause of osteoporosis in women. Um, and in men, again, usually when I see a man who has low T, confirmed low testosterone levels, one of the initial tests that I always do as part of my evaluation is a bone density test, because men with low testosterone are very likely to have some kind of bone issue. And then there are hormones that you might not think about, but actually can affect bone in a negative way. Hyperthyroidism, which is overactivity of the thyroid gland in long periods of time of untreated hyperthyroidism, definitely accelerates bone turnover, and that can exacerbate someone who's already at risk for osteoporosis. Parathyroid Parathyroid disease is also very classically associated with osteoporosis. Parathyroid glands sit right next to your thyroid. The thyroid gland is like a butterfly in your neck, and the parathyroid glands kind of sit on the corners. So we have four. And a lot of times someone comes in, they find out they have high calcium, or they had a kidney stone, or they're 30 years old and they broke their rib, doing something silly that doesn't make any sense. A lot of times you'll do a little bit of testing and you'll find out that there is an elevated parathyroid hormone level that's contributing to this problem. So it is always good to kind of go and have this conversation with your provider if you have these kind of unusual factors, or unusual bone density scores, like maybe you weren't supposed to get a bone density test at in your 30s, but you happen to go to someone who happened to order the test and it shows really abnormal scores. What do you do with that? I mean, we definitely would do what we call secondary workup, looking for other potential causes of bone loss. And I will say there's one that's not on the list that I forgot to add, but cortisol. So whenever someone comes in to see me for a bone workup and they are wanting to make sure that they don't have any other medical conditions that are causing bone loss, we look at obviously their estrogen production. We do parathyroid testing. And the only other hormone test that I would consider doing is a cortisol test, because cortisol excess, which is generally called Cushing syndrome, has been associated with many comorbidities, including osteoporosis. And sometimes that's the only presenting symptom. So it is really important to rule it out, because cortisol excess not only can cause bone loss, but it can cause diabetes, weight gain, hypertension. And so obviously you want to make sure that you're not putting people at risk for other medical problems.
Absolutely. Yeah.
And then, in terms of like for preventative purposes only, what treatments are available that you can do aside from, kind of like lifestyle modifications, which we'll go into in the next few slides. But this is kind of this is a very interesting topic right now, because and I don't know if Dr. Dweck is going to be talking about this in your future webinar with hormone therapy, but you know, 25 years ago or 22 years ago when the Women's Health Initiative came out, and people were discontinuing hormone therapy because they were concerned that they were at risk for possible complications. A lot of women were taken off or not prescribed hormone therapy for, I want to say, decades. And what we do know, and we've always known, is that when women were taking estrogen with progesterone or estrogen alone, if they didn't need progesterone, that they were definitely protecting their bone, because we know that estrogen is a protector of bone. So in terms of what we can do aside from supplements, exercises, is kind of reconsider this role of estrogen therapy. If you have hot flashes and your last period was like 2 years ago and you're miserable, another reason, and you're scared because you have that information from 20 years ago in the back of your head, your mom had breast cancer, just like things that make you nervous. One thing to consider is, well, I know that if hormone therapy is going to improve my hot flashes and also protect my bones for the next few years, maybe the more reasons to take it, the better. So that is something where I would say I wouldn't necessarily do hormone therapy if it's just to prevent, unless you have a really strong family history of osteoporosis and and you're really terrified about doing just the kind of like the standard of care. I think in that situation, if there's no other contraindications, it still could be a consideration, but I definitely would consider it if you had even one symptom of menopause. There are other medications as well that are non-hormonal, such as raloxifene, or Evista is the brand name. It's a selective estrogen receptor modulator, and it has estrogen-like properties on certain tissues in our body, including the bone. So it does actually prevent bone loss, and it is also used as a treatment for osteoporosis. It is a second line treatment, it happens to also reduce the risk of breast cancer. So it's kind of like if you were worried about osteoporosis in the family and you have a strong family of breast cancer and you don't want to do hormone therapy, but you're really worried about osteoporosis, Evista might be a good option to try. If there are some women, there's one more medication that's newer. It's called Duav. It's actually a combination of oral estrogen with a selective estrogen receptor modulator, and it's actually been approved for osteoporosis prevention. And it's also, because it contains estrogen, it is beneficial for hot flashes. So a good candidate for this treatment would be someone who doesn't want to take progesterone, which if they have a uterus and you want to go on hormone therapy, you have to do estrogen and progesterone together. You can't do it alone because of the risk of endometrial hyperplasia. So in people who don't tolerate progesterone, have side effects of progesterone, or have tried it and don't like it, this is a good alternative. But again, known to be preventative for bone loss. So that's another really good kind of consideration. And again, it's not a very well-known medication, although I know some gynecologists are really kind of promoting it as part of their bone health, agenda. Also, some of the traditional osteoporosis treatments, just as an aside, are approved for prevention, but I usually don't recommend those until they actually have evidence of osteoporosis.
I think it's so interesting. I love these reminders of like how all of these really, like all of the hormones, which endocrinology is all, they're all so interrelated, right? And so these conditions that we, maybe not didn't talk about as much, we maybe didn't talk about, osteoporosis so much, or low bone mass as much, certainly in younger ages. But I mean, I'm sure there's a number of people on this call right now who have a family member, just like your aunt, who's had a fall, or a good friend, or cousins, like people that they know that they care about, that have sort of been diagnosed a little bit too late for this. So I feel like it's so interesting when all of a sudden you're realizing the interplay of all of these things, and that we can take some measures now and really be aware and knowledgeable. And I think it's great. I think it's such a great topic for everyone. Before we transition into some of the nutrition stuff, I'd love to just take a second, pause. Does anyone have questions about anything that Dr. Im has talked about? Any slides you'd like me to go back to? Laura is asking in the chat, reclassed. She's asking, are you able to discuss reclassed?
Absolutely. So reclass or zoledronic acid is in the class of a bisphosphonate therapy, which is considered first-line treatment for osteoporosis. It is so bisphosphonates are they're in a class of medicine called anti-resorptive therapies. So they slow down the loss of bone. They don't have any major impact on the cells that produce bone or osteoblasts. They really focus on the osteoclast activity because when, especially in menopause, when estrogen levels drop, the osteoclast activity accelerates. So we target the cells that are causing the thinning of the bones. You know, the word osteoporosis really means porous bones, like the bones are actually forming holes. So when we give people medication, we're trying to just slow down the formation of the holes. Reclass is a really great option for people who don't tolerate taking pills. Sometimes people take the oral forms like Fosamax or Actonel, and those are on a more regular schedule, like once a week or once a month, and they get stomach upset or they might have some negative effects from taking the pill on a regular basis. Also, the way that you have to take the pills, you have to take it on an empty stomach. You have to take it with a full glass of water because early on they were concerned about esophagitis. And you have to wait sometimes 30 minutes to an hour to lie down or eat because, again, that theoretical risk of esophageal damage. So reclass is a really nice alternative. It is definitely the most potent form of the bisphosphonate class. It is very convenient schedule. It's only once a year. I forget the schedule for osteopenia. I think it's like every other year. I could double check that and let everyone know. But you know, for osteoporosis, we use it traditionally 3 doses in 3 years, and it's a really great way of managing mild osteoporosis where the T scores are just borderline, or someone has, you know, low bone mass, right? They have osteopenia, but they have like a high fracture risk, which might have been calculated by a FRAX score or an elevated, a low trabecular bone score, like just some other possible, you know, reasons. Or if you're on steroids because you have rheumatoid arthritis and you're occasionally having to take big doses of prednisone over the course of your life. I sometimes like to do the reclass because sometimes you do the 3 infusions and then you can take what's called your drug holiday. But reclass is a really good option for a lot of people, especially I would say who are not at very, very high risk for fracture, but what we call like a high risk for fracture.
Great. Thanks for that question. And then we did have just a clarification. Can you just clarify hormone replacement therapy and the risk of breast cancer? Does it increase your risk? Does not increase your risk? I know you just talked about it briefly.
Oh, so I figured Dr. Dweck would probably talk about this next week,
Right.
but traditionally, if you look back at the data, it obviously depends on the time frame in which you start hormone therapy. They actually, when they looked at the major studies from 20 years ago, they found that if you didn't have a uterus, if you just were taking estrogen, there was actually a reduction in risk of breast cancer being on hormone therapy. And then if you were taking progesterone, it was not a reduction in risk. In real time, I mean, it really depends on when you start hormone therapy in relation to your age and in relation to your time of menopause. So if you start hormone therapy in your 50s, and traditionally the time frame that we're talking about is 50 to 60, presuming that your last menstrual period was around 50, so less than 10 years from your last period, the risk of breast cancer related to hormone therapy is not increased. So it is very important to consider the time frame in which you're talking about starting hormone therapy. And this goes for all the, generally all the complications that have been associated or concerns that have been described with hormone therapy. The bottom line with hormone therapy is the earlier you start, the less likely you'll experience, a complication. I will say if you end up having um, breast cancer, it's not that the hormone therapy caused the breast cancer, but, and this I've seen in men over the years who have low T, who take testosterone, if you have an underlying risk, it will potentially accelerate the risk, meaning it will bring it out maybe a couple years sooner than if you didn't take hormone therapy. It's not that it de novo came out of the blue because you're on hormone therapy. So it is something to obviously consider if you have if you have genetics that make you at risk for breast cancer. But if your mom had breast cancer, that doesn't mean that you're not a candidate for hormone therapy. You definitely would go through a screening process and just kind of have a discussion regarding the risks and the benefits. And if your concern for that is high, but again, you wanted to take treatment for preventing bone, then I would say maybe Evista, which, as I mentioned earlier, is actually shown to reduce the risk of breast cancer, could be a really good option for you.
Great. Thank you. Thank you for clarifying that. I hope that helped answer some questions. I know Sharon has a question, but I just want to be mindful of time. Let me go through a couple of my slides and then we can go back to some of the HRT stuff at the end. Or also, Sharon, we're going to be discussing this with Dr. Dweck next week as well. So just in the interest of time, we're going to keep rolling a little bit and then we can always come back and continue to answer questions. Okay, so now we're going to kind of talk a little bit about the nutrition aspect of it, and certainly Dr. Im hop in as well, because the wonderful thing about Well by Messer is that the doctors here also love talking about nutrition and talking about sort of all the other parts of preventative medicine, which I think is just really great. I love working with physicians that are also super keyed into nutrition, just like I am. So bones, right? Obviously, bones are the foundation of our body. They provide structure, support, protection. And proper nutrition is really essential for building and maintaining our strong and healthy bones. So key nutrients that are critical for bone health. None of this is like, no, I'm not releasing any new information here. So, right, everyone knows about calcium. Everyone knows that vitamin D, and everyone is really talking about protein all the time. So calcium is that, we've talked about a little bit already, the primary mineral that forms the structure of our bones and our teeth. And it's really essential for that bone growth and development phase, which we talked about earlier, which is really kind of ages 0 to like 20, sort of is that really main high growth and development and sort of structural, making sure the structure is sound. And then after that, we tend to, it's like sort of putting money in the bank, right? Like that's when you're in your savings mode. And then after that, I guess maybe once you hit 30, you start to sort of remove your savings, you remove your calcium savings. So we really want to be putting that calcium in early on. And vitamin D, it plays a really critical role in helping our body absorb and utilize the calcium. As a lot of people know with supplements and we'll talk about that as well. But a lot of times like you can flood your system with 100 grams of protein, or you can flood your system with 9,000 milligrams of vitamin C or something, but it doesn't mean the body's actually going to use it. The body's pretty smart. So sometimes it needs a partner to help it work. And with calcium, you need that partner of vitamin D to appropriately absorb and utilize what's coming in. I really, and I talk a little bit about, I mentioned the 1,000 milligrams a day for men and women, 600 IU or 15 micrograms per day for men and women for vitamin D. And there's a supplement that I really like. Thorne has vitamin D in oil, in an oil suspension, and that we'll talk about that as well. But vitamin D is a fat soluble vitamin. So it really is, again, it needs that buddy to be better absorbed in order to do its job for the calcium. It's like everyone holding hands on like a chain, right? Like the vitamin D needs its fat buddy and the calcium needs its
Unlimited
vitamin D buddy.
clubbing.
Oh, does someone have a question? Okay, well,
Please
feel
wait
free to
while your
share.
seat is being extended.
Okay.
Thank
Maybe
you for your visit. We look
remember
forward to
to
seeing you
mute.
again.
Okay. So, anyways, and then we've got protein, right? I know we talked a lot about protein a couple weeks ago when we were talking about fueling our workouts and certainly with our glucose maintenance and our metabolic health. But it really also helps, protein helps the building blocks for the bone matrix and supports our muscle strength, which is really important for bone health. And I just listened to this super cool, I'll talk about another slide, but I listened to this really great podcast recently talking all about how muscle helps build bone. And it's like you don't necessarily think that, but it's that whole reasoning of doing like heavy strength training because like the muscle needs to like pull on the bone and that's what makes the bone rebuild itself and build itself stronger. Like the whole chemistry of it is just fascinating. The body is incredible. Okay, so those are the things those are the things that we need. And again, we talked about this. I sort of bring this up every time I do a presentation. And we have such an educated audience. Certainly for these calls. So I'm not really talking about anything that people don't know, but these ultra processed foods can actually have a significant impact on bone health. Research shows that adults who consume more ultra processed foods face a higher risk of osteoporosis. For women, each 1% increase in ultra processed food consumption is linked to a 1.9% rise in fracture risk. And the highest consumers of ultra processed foods get around 76% of their daily energy intake from these types of foods. So, it's concerning as ultra processed foods, they lack nutrients. That's the whole point. They're processed and the nutrients are really taken out of them. Now, we can debate it. We kind of debated it last week. Some people consider like cereal or something, maybe an almond milk that is fortified with calcium to be like it's a processed food, right? This is a food that doesn't necessarily contain this nutrient or mineral, and we're adding it to it. So some people are like, no, no, I eat super clean. Like it's like I get all my whole foods and everything like that. I'm like, well, but there is something to be said if you're not taking in enough calcium. Why not have the almond milk with extra protein or the extra calcium added to it, or the cereal that does have these extra nutrients in there? There is a place for processed foods in the diet, maybe just not the ultra processed foods.
And I would actually chime in that dietary sources are definitely better absorbed. So it is something to consider when you're deciding how you're going to get this calcium into your body.
Absolutely. Absolutely. And we'll talk about that as well. Um, so supplements. So again, we're gonna talk about the whole food sources are at the bottom. And I am like, it is my job drilled into me from school. We always recommend getting these kinds of nutrients from whole food sources because again, like I said, they need their buddies. Generally, these foods are better absorbed when they have their pals with them. And when you just take a capsule, we all know these are unregulated. So what the label says doesn't necessarily contain in each capsule, unfortunately. And there are reputable brands that Dr. Im and I like. But sometimes these supplements are not what they seem to be, and or you're taking them in such quantities that the body's like, I can't do much with this. You're just giving me a pill and maybe you're not giving me my fat buddy in order for me to absorb it. So I'm just, I'm not going to utilize it in the right way. So you might be thinking you're doing your body a good service, but at the end of the day, maybe you're just peeing it out or it's just not going where it needs to go in the body. That being said, sometimes we just simply don't take in enough of these foods in order to meet some of these minimums. Potentially, people have lactose issues or allergies or things like that, and so they avoid certain whole foods in the calcium in the dairy food section of calcium, which again is fine. A lot of children drink milk and then eventually they don't like it. They don't want to continue to drink it. It upsets their stomach. Many adults, I mean, I don't think I've ever gone out to dinner at a restaurant and seen any adult order like a glass of milk with their dinner. I which is like kind of funny. Maybe we should open like, well, I know there's Milk Bar, but that's like dessert. But maybe someone needs to open up like like a high calcium um drink option. But anyways, sorry, I'll stop joking about it. It's not it is serious. So sometimes these calcium supplements can be effective, but they're generally effective in smaller doses, around 500 milligrams or less. And people always ask me like, well, there's 1,000 different forms of different stuff, what should I take? Calcium citrate is better absorbed than calcium carbonate. And you want to take it on a regular basis. You can't just, it's not like a one and done where all of a sudden you just take, 500 milligrams one day and you've solved your low bone mass issue with your doctor. So really important to do that. And it does not require the presence of acid to be absorbed by the GI tract. So that's good to know as well. Vitamin D, essential for that absorption and mineralization. They work hand in hand, they're buddies. D3 is more effective than D2, and blood testing can determine an optimal dosage. Again, I said the 600 IU. Sometimes physicians will recommend a higher dosage if you are deficient. Magnesium and other minerals. Magnesium, I feel like I love it that everyone's talking about magnesium these days. Like it is so buzzy. People are like, oh, I take it for this, I take it for that. There's lots of different kinds of magnesium, but it's really wonderful because it aids that vitamin D activation and calcium utilization. Again, the body is amazing and it doesn't work in silos. The body works in sort of this amazing, cooperative way. And so in order to maximize the absorption and really trying to bump up these metrics, these calcium or these bone density metrics, you have to make sure you're getting all of it together. And the K2 also helps, and it directs calcium to bones rather than to soft tissues. And then other trace minerals also help with this. So again, this is not to the sense of like, I'm going to sit here and prescribe you 9,000 different supplements through Fullscript. It's about eating a balanced diet, right? You're going to get these minerals and some of these trace minerals in a balanced diet. So it's really important, and I think it's great that people are taking magnesium supplementation. But we can also get a lot of this stuff through our food. I will say there's that. The thorn vitamin D and K that's suspended in the oil and the MCT oil is really wonderful in that sense because it has the vitamin D and the K in it. And you just take like two little drops under your tongue. So it's wonderful. And then the whole food sources, right? So we say dairy products. I do caution my patients that Greek yogurt actually it's higher in protein, which we want, but it's actually lower in calcium. So sometimes I'll say, listen, if we're really trying to increase your calcium intake, you could actually just choose regular style, like I don't even know if you can find that in the grocery store that much anymore, but I feel like it's all Greek yogurt or like the really thick yogurts. But just like your old school, like Dannon yogurt, like the more runny type of yogurt actually has higher calcium. And I talk a lot about leafy greens. People are wonderful about getting those in. Sardines are wonderful, almonds, tahini, some ideas, obviously you can do a fortified cereal with milk, spinach and cheese omelet. And I really like to talk a lot about tofu as well. I think soy is kind of an underrated source of calcium. Particularly, there was a lot of noise about some headlines. I don't even know how many years ago about like soy causing all sorts of negative impacts in men and stuff like that. And I say, if you actually look at the research that was done in animals, you could never possibly take in enough calcium as these animals were given. And we can talk next week also sort of about the phytoestrogen impact of soy on the body, but it is so minimal. And it actually, when you look at like population studies, the populations that take in more of these soy related products actually have a lower incidence of so many of our chronic diseases that we see in America. Any questions about some of these foods out there? I love that dark chocolate is in there. I love that avocados are in there. Again, none of this is like super, super out of the box. Like, I'm not really telling people some brand new information here, but I really think that, if you want to take some things away, potentially look at the type of yogurt that you're having. really, the sunlight exposure is a wonderful way to get your own vitamin D. And what I think is interesting too, and Dr. M, please, please add or correct me if I'm wrong, but depending on when you're getting that vitamin D test, if you're getting your vitamin D, your blood drawn or something like that, and it's like the end of the summer, and maybe you play a lot of golf or you play a lot of tennis, it's going to look maybe higher than if you get your vitamin D tested like after the winter months, right? Like if you get it tested in like March or April. Is that kind of correct? So it kind of depends on where you are in terms of your sunlight exposure.
Oh, definitely. I have seen people where they were like, not, they were like staying in like a different part of the country, and the vitamin D level definitely shifted as a result of their sun exposure from being in a different part of the country.
Yeah. So, some people maybe they spend their winters in Florida and that's, like that is or a sunnier state where they are getting more sunlight exposure. But if you're not, if you're more of a skier or you're just, up here in the Northeast, some people will just supplement during sort of those like a fall, like maybe like October to April or something like that. So it's not that you necessarily have to be supplementing your vitamin D throughout the whole year. I also like to give a little shout out to prunes. I didn't add those in there, but I think that they are like, I mean, prunes could be like the next kale. I mean, like I feel like dates made like a really big comeback in the smoothie world. And prunes really could use like some moment in the sun. Ha, get it? In the sun. So prunes are a great source. They are a great source of vitamin K and potassium and polyphenols that benefit bone. So nothing wrong with that in like one or two prunes to your morning routine. They also really help keep you regular, which is always good in my book.
And then one kind of like rule of thumb when you're looking at like labels, because sometimes you just don't know how much of this am I supposed to be consuming to get my needs. When you look at the label, it gives you the serving size, and then it also gives you generally the amount of different minerals, including calcium. So it's either going to be reported as milligrams or as a percentage. So if it's reported as a percentage, like if it says 10%, then just add a zero to the end, and that gives you kind of like a ballpark. So it'll be 100 milligrams of calcium for whatever that food is. And that just kind of helps guide your decision making about how much you're actually consuming on a daily basis. And you can make adjustments so that you can try to maximize your intake by the end of the day.
Awesome. That's a great tip. Yeah, that's really helpful. Yeah, because sometimes the food label or the supplement label will just give it to you in a percentage. Yeah. Okay, really quick, because I know we only have like 8 minutes left. Time flies when you're talking about bones. So weight-bearing exercises like walking, jogging, and dancing, they stimulate that bone formation through the impact with the ground. Resistance training is super cool. It's so interesting that like the way the body works is that pulling, like the muscle pulling on the bone at those attachment points, because the muscle attaches to the bone like at the ends. It signals the body to like increase the bone density. It's fascinating. And I actually was this podcast I was listening to was it reminded me that a lot of times actually runners can have a lower bone density than athletes that do more of these like a dancing or a walking. And they think it's because really elite runners are actually very light in weight, and so they actually aren't really pounding on their joints as much or sort of forcing that bone building. But again, we talked about this last week. I actually talked about it, I think every week, talking about that resistance training. So again, yet another benefit to making sure you're lifting heavy, because the heavier you can, the more that signals that not only your muscle to get bigger, but your bones to get bigger. These balance activities are really, really, really important. Again, it's this cascade that Dr. Im mentioned again. If someone, if they fell over, like like that sort of starts the cascade, or they trip, or something happens, they stumble. So making sure that we do that functional strength, right? Again, like I said, you want to make sure you have muscles that you can like, pick up the groceries and carry them, and then also just hold on to them, right? So you need the functionality to pick up and put them down, but you also need the strength strength to hold onto them. And you need the ability to twist, to turn, to put things up, to go down, to pick things up, to get in and out of a chair. So many times, and also just to be able to lift your legs up to get over a step or watch out for a curb. How many times have we seen someone who looks very unsteady on their feet, right? And so we really want to make sure that including activities like Tai Chi and yoga are really wonderful at helping increase coordination. Or if you work with a trainer or someone, there's also a billion YouTube videos just all about these functional movements, these twisting, turning, pushing, pulling, getting up, sitting down. And then incorporating just really a variety of these exercises can help strengthen bone at any age. And so really the key takeaways, like our last slide here, high level, we need to nourish our bones. And for many of us, we are not in our teens. I don't think we have any teenagers on the call, but if we did, that would be awesome. I don't think we have any teenagers, but if you know a teenager, if you are around any teenagers, just encourage them to, again, have a varied diet. Make sure that calcium is a part of their diet. But even now, at whatever age you are at, it is not too late. You can absolutely make these wonderful changes to prevent a low bone mass, or if you do are at a bone mass, you can make wonderful changes to prevent osteoporosis. And a lot of times that's just minimizing the ultra processed foods, making sure you're getting that calcium, getting that vitamin D, staying active, and really doing that heavy lifting, knowing your risk. So talking to your doctor and saying, hey, maybe this is something that I would like to know kind of where I am because I want to start tracking my trends over time. Where am I at 45? Where am I at 50? Where am I at 55? Or again, knowing your family history or, whatever your physician recommends. Anything else you'd like to add at the end, Dr. M?
No, you summarized it excellently.
I love it. I love it. So we have 4 more minutes left. Karen has a question in the chat about the impact of GLP-1s on bone and hair. Also, do the bisphosphonates cause hair loss?
Um, so that so GLP-1s and bone loss, I don't know offhand the official data on that, but I would suspect, and I could definitely follow up and provide like a follow-up email, through the practice. That if you're losing weight, which as we know, GLP-1s have been unfortunately described with muscle weight loss as well as fat mass loss, that there is going to be a potential for bone loss as well. So, obviously when someone is taking a GLP-1 and they're looking to lose weight, these bone strengthening exercises are extremely important because another aspect, if you consider, is that when GLP-1 receptor agonists are taken, you end up with a very restrictive diet, and it might restrict your calcium intake and your vitamin D intake. So there are going to be multiple factors involved with potential bone loss due to a GLP-1 receptor agonist. But I can look and see if there's been actual research studying this. I'm sure that there is some information, maybe just scientific information that would be worth knowing. Hair loss and GLP-1s, my experience with hair loss, with weight loss specifically, is that hair loss is definitely a reaction to stress. And when people lose rapid amounts of weight in a relatively short period of time, there's definitely a risk for hair loss. It's been described in COVID literature. People who have COVID, with the stress of the infection, can cause hair loss. I have seen it in patients who've taken GLP-1s. It doesn't happen to everyone, but if it happens, it generally happens to the people who lost weight relatively quickly. And so my only response to that, or my only suggestion for that, is to try to minimize how much weight you lose. I mean, I know the idea is to lose as much weight as you can, but in the long run, you will have a better chance of maintaining weight loss if you do it in a slow and steady pace. So aiming for like a half a pound to a pound a week, I think, is kind of like a good target. Hair loss related to weight loss will definitely level off as the weight loss slows down and becomes more kind of like stable, and kind of your body adjusts to it. There's a lot of literature about bariatric patients where they have weight loss and resulting hair loss. Bisphosphonates and hair loss, I don't think there's any, it's not considered a major adverse effect. Bisphosphonates can definitely cause joint pains, body aches, specifically the oral bisphosphonates, you can get stomach issues a lot of times because of the way you have to take the pill. Um, the reclass medication, usually with, especially with the first infusion, which is really a 15-minute treatment. A lot of people do get flu-like symptoms, and that's very typical, and it has to do with the potency of the drug. But the good news about that is if you are able to power through those symptoms, which we recommend hydration, Tylenol, just kind of like taking it easy, relaxing, that subsequent infusions will be much better tolerated. But hair loss specifically, I would say, is not common with bisphosphonates.
Great. Thank you. And then we just had a question about magnesium. Dawn, I'm not sure if you're looking for like a brand, but brands that I really like are Thorne and Pure Encapsulations. I find them to be really reputable. Dr. Im, do you have any supplement recommendations or like brands that you prefer?
Specifically for magnesium, no. For, for the calcium, sometimes I give people names, but again, for me, it's more whatever you can tolerate, because some people just take certain calcium supplements and they get constipated or they get, nauseous. And so you have to be really kind of like mindful of who you're working with. And then those patients, I generally try to push for the dietary sources.
Yep, got it. We have a question about postmenopausal women going back on going back on hormone replacement therapy. But Karen, I would say not that I don't want to answer this, but we are at time. And next week we're going to have Dr. Dweck, our gynecologist here, talking all about women, hormonal and hormones, nutrition, all of that. So I think it might be better served for next week. And Kimberly is asking if there's a way to watch these sessions over again. Yes, we are recording this one and we have recorded all the previous ones. So if you just contact the front desk at either the Greenwich location or the Upper East Side location, the office managers can send it over to you. They can also send you the slide deck if that's of interest as well. And anything else? I know we're at time. I want to be respectful of Dr. Im's time. Does anyone else have any last questions before we go? All right. Well, I really appreciate everyone's time. Thank you, Dr. Im, for coming. This was really helpful. I think everyone learned something, and we will see you next week with Dr. Dweck. And have a great day, everyone.
Bye.
Bye.